Let's start this nice day in Venice with looking at some recent data on the etiology of lower respiratory tract infections in older adults and possible knowledge gaps. Respiratory diseases are the third common cause of death in Europe, and pneumonia is the second most important in this category. Now, mortality still is around 10%, and as you can see, even in high-income countries, lower respiratory tract infections are still the sixth cause of disease, even though there is good health care and, of course, antibiotic treatment. The burden of the disease is expected to increase as the incidence and prevalence is age-related and the consequences as well. Now, when we look at the etiology, let us look at three aspects. The first one will be host factors. The second, the pathogens that will be incriminated in pneumonia, and then a short look at some lessons to learn from vaccination and effects on microbiology. Talking about host factors, I will not talk about the classical risk factors like COPD or smoking, but rather focus on some age-specific aspects. Aging is associated with anatomical and functional changes. Anatomical changes include decrease in compliance of the chest wall due to calcification of rib cage and its articulations. And as you know, many older patients suffer from vertebral fractures inducing thoracic kyphosis. Age-related sarcopenia and frequent malnutrition will induce a decrease in the strength of respiratory muscles, and there is also a decrease in the elastic recoil of the lung itself. Now, there is a decrease in the small airway diameter, and there is an enlargement of the alveoli, which has often been named senile emphysema, even though there is, of course, obvious differences with the classic emphysema in COPD patients. Now, with age, we also observe a decrease in mucociliary clearance rates and a lower sensitivity of respiratory centers to hypoxia and hypercapnia. These anatomical changes will induce functional changes with an increase in the functional residual capacity and an increased workload on respiratory muscles. Let me stress, however, that the respiratory system in older adults remains capable of maintaining adequate gas exchanges during the lifetime, during the entire lifespan, but the decreased reserve will, as in many situations in geriatric patients, be revealed in stress situations like infections, such as infections. Here you can see the increase in the residual volume with age and the decrease in the expiratory reserve. And on the left side, you can see the evolution of the forced 1 second expiratory volume with age. And you can see that, as we talked about bio-age or biological age yesterday already, that there is 70-year-olds that may have the same capacity still as some 20-year-olds. Another important aspect of this scheme here, of this figure, is also that you can see that there is a much larger spreading of the values. One of the characteristics of older people is that they are much more heterogeneous than younger persons. Younger persons, they resemble each other much more than older adults. Now, an important aspect in older patients is dysphagia, or swallowing problems. We have changes that are associated with age, which are decreased taste and smell. Decreased taste can be influenced by vitamin or trace element deficiencies. We have a decreased sensitivity of the lateral parts of the lung, the salivary gland atrophy, and here I have to stress that medication often is a reason for dry mouth and increased swallowing problems. Patients with artificial teeth with dentures, dental prosthesis, have a reduced mastication capacity, and there are delayed reflexes in the esophageal sphincters. Now, even in younger, healthy adults, about 50% seem to have seem to aspirate small amounts of oropharyngeal secretions during sleep. And this increases with age, and there is about 60 to 80% of older adults without overt dysphagia that will have abnormalities when examined with video fluoroscopy. Now, fortunately, these small aspirations do usually not lead to repeated infections due to the fact that the burden, the bacterial load of the swallowed content is quite low, that there is a coughing reflex, forceful coughing, that there is an active ciliary transport, and that there in normal, if there's a normal humoral and cellular immune mechanism, the organism can react to this insult. As you know, dysphagia is, of course, a prerequisite for aspiration pneumonia. And then I talk about obvious aspiration, but silent microaspiration may be a cause and has been incriminated not only in aspiration pneumonia, but also in most of the cases of community-acquired, nursing home-acquired, and even ventilator-acquired associated pneumonia. But swallowing is one thing. You have to have a poor oral hygiene with increased bacterial loads, or gastroesophageal reflux may be associated with anti-acids to have more bacteria in the gastric content, and decreased host defenses to induce pneumonia. A short word about denture, about the dental prosthesis. We know that 80% of these prostheses will be contaminated, will be colonized, and it has been shown that using the dental prosthesis at night will increase the problems with swallowing, with aspiration, with microaspiration during the night. Last but not least, immune senescence. You know that the lifetime antigen stimulation, that latent viruses, thymic involution, cellular senescence will lead to chronic low-grade inflammatory profile in older adults. There is an increase in memory. There's an increase in memory lymphocytes, B and T cells. These are T cells here indicated over age. Although there is thymic involution, you can see that in the first part of older age, the changes are quite low. The reduction in naive T cells are quite low, that there is a bigger clonal expansion of CMV and herpes virus monoclonality here. And you see that that is mostly at much higher ages that we have a large increase of CMV clonal expansion and rather a decrease in herpes virus clones. Now, it may be important to realize or to emphasize that actually reactions to influenza specific B-cell responses in the elderly actually are mostly based on mutational modifications of the existing immune B-cells rather than recruitment of the naive B-cells or that have been reduced with age. Now, all these anatomical and functional changes will lead to increased risk of pneumonia in older adults and to more difficult diagnosis in these patients. And as you can see here, the clinical presentation of pneumonia in older adults is atypical. And you can see that the classical signs like cough, fever, and dyspnea are present in about half of the patients. Half of the patients have the triad of these three classical signs, and about 10% have none of them. So the diagnosis of pneumonia in older adults is much more difficult due to the described changes in anatomical and functional status of older adults. But let us now have a look at the pathogens, the microbes that are responsible for lower respiratory tract infections. Now, when I started to prepare this talk, I went back to a classic publication by the colleagues from Geneva from 2004, and I found this quite nice list of pathogens. And I thought, well, you see here Streptococcus pneumonia, Haemophilus influenza, Staphylococcus aureus, and Moraxella catarrhalis are the most frequent classical pathogens. Among the non-typical, the atypical pathogens, you would have rather chlamydia pneumonia rather than the Mycoplasma pneumonia that is more frequent in younger adults. but that has been indicated as being quite rare in the oldest old, and Legionella still being present, with about 4 or 5% of viruses in these patients with community-acquired or nursing home-acquired pneumonia. So 2004 is quite some time ago, so I went to look if there were more recent data, and I found the publication from Vrije from 2014, who cited exactly the same pathogens. And actually, he based his information on the one from 2004. So I thought, well, my presentation is done, no new data, things are quite easy, this is an easy one, and my presentation is done. Unfortunately, when reading further, I saw that most of the experts think that defining the etiology of pneumonia still is a messy business. And that is because even recent studies with extended pathogen detection methods have been able to show the responsible pathogen in only half of the cases at best. So I went to a colleague from France here, and actually the yield of microbiological samples seems to be that bad that the American recommendations don't even ask us to take microbiological samples in order to find the pathogen. Whether this is due to post-Trumpist depression, I wouldn't dare to say, but fortunately, I found these French colleagues that were en marche already before the election of Macron and made a big effort in order to kind of document the etiological pathogens in lower respiratory tract infections. So they followed European guidelines from the European Respiratory Society and the ESCMID, where they took blood cultures, sputum samples in all patients with community-acquired pneumonia or other, and did urinary antigen detection. Now, they did a very good job because they had samples in 90% of the patients, which is very good. Unfortunately, if you look at the samples they had and at the results, you see that sputum samples were obtained only in less than 20% of our older patients, and that positivity rates were about 50% in community-acquired and much lower in nursing home and hospital-acquired pneumonia. Blood cultures were much more easy to obtain in 80%, more than 80% of the patients, but the yield was even worse. Less than 10% would be able to identify the pathogen. So if we look at the total data here, you see that this is a big deception, that you would have a lot of samples taken with a very low yield of positive results. Here you can see the details of the pathogens identified. It's again Streptococcus pneumonia. There is Staphylococcus aureus, methicillin sensitive, and Enterobacteria, and you have viruses again at about 5% of the cases. But the important thing here is that you would not have a pathogen documentation in 3/4 of the patients. So it really is a messy thing. And these enthusiastic French colleagues finally concluded that microbiological samples that were taken in more than 90% of their patients could not reveal any significant outcome-related benefits when they confronted the microbiological results to the antibiotics given and the clinical evolution of their patients. So they concluded that they could not support systematic microbiological sampling in older adults in lower respiratory tract infection in their cohort. So they advise to improve the efficiency of the microbiological sampling, to limit these investigations to patients where the result would really change the antibiotic treatment, like, for example, not doing urinary antigen for Streptococcus pneumonia in patients that are already treated with beta-lactam as probabilistic antibiotic therapy. Of course, they advise to take the samples before starting antibiotic therapy and to have that in patients that would not respond to treatment. Let me emphasize here that the bronchoalveolar lavage in older adults is very well tolerated and that we should not hesitate to do further investigations, like more invasive investigations when the patient does not respond to treatment. Now, they conclude also by saying that other ways of doing the sampling should be sought for, and that molecular biology tools, that PCR might be a promising tool for the future. Now, fortunately, we don't have to wait for the future because the future is here already, because at the same time in 2016 there has been a publication by a group from the UK, and they looked at 323 patients hospitalized in Edinburgh, in 2 tertiary care hospitals, and they based the clinical diagnosis on the association of at least 3 symptoms and positive radiological findings. Now, they had, in most of these patients, one single lower respiratory tract specimen, most of the times a sputum. Actually, it's from here that they started to go back to the clinical situation of the patients. And what they did was multiplex real-time PCR for 26 bacteria and viruses, which I have listed on the right side. So this is really broad-spectrum microbiological diagnosing. And when we look, this is some information about the patients included in the study, mainly male patients. The cohort was somewhat younger than the cohort in France that had a mean age of more than 80 years. Here you see that only 30% of the patients were aged 75 or older. They had moderate, I would say, comorbidity. They had rather low severity index. The CURB 65 score, 50% scored 0 or 1. But however, they had 40% that had to be admitted to the intensive care unit, and 1 in 4 even had to be intubated. What is particular in this study is that antimicrobials, antibiotics, had been administered in more than 80% of the patients by the time the microbiological sample was obtained. So, of course, you know that this is a barrier to good biological documentation of the pathogen. However, their results were impressive. If you look at this, if you look here, you can see that they had a pathogen detection in 87% of the patients with community-acquired pneumonia, compared with less than 40% in culture-based methods. Haemophilus influenza and Streptococcus pneumonia were the most frequent pathogens, along with a wide variety of typical and atypical pathogens. And viruses were present here in 30% of the patients, which is more than previously indicated. However, viruses alone were found in only 5% of the cases. And when a virus was detected, 80%, more than 80% thus were co-detected with bacteria. Now, 30% of the patients had several bacterial pathogens at the same time in this series. What is reassuring is that about 100%, almost all the samples that were positive in culture also showed positive results with PCR, that there were less than 10% that were not of the pathogens that had not been included in the PCR, that had been found in sputum, in the cultures. And as I said before, more than 80% had received antibiotics before sampling. In these patients, 78% still could be, the pathogen could still be detected, compared to 30% with culture-based methods. And as you know, and as they state here, antimicrobial administration was significantly associated with the patient having culture-negative lower respiratory tract specimens, which is something that we frequently see in our clinical practice. Here you see the details of the pathogens they detected, and you see the importance. I just indicated here the vaccine-preventable pathogens, influenza and Streptococcus pneumonia, which are quite prevalent in this cohort. And you can see that 81% of the patients showed positive results for bacteria, 30% virus. And I want to insist on this information here, which is the colony-forming units that they were looking at. The problem is that many of these common pathogens are colonizing the oropharyngeal cavity. And of course, if you do PCR, one of the risks is overdiagnosing. So what they did actually is they made a standard curve with their PCR results and culture results, and they would have a standard curve in order to see if their PCR results showed sufficient bacterial load in order to conclude that it was infection and not just colonization. Now, maybe the most important finding of this study is that the authors looked at the antibiotics that were used in these patients, and that they conclude that more than 70%, 77% of the patients could have benefited from de-escalation in antimicrobial therapy. Because this, of course, is of relevance for our consumption of antibiotics, hopefully for resistance of hopefully for antibiotic resistance in the pathogens as well, but I will come back to that later on. Now, let us shortly look at some effects from vaccination, or observations from vaccination. In the United States, there has been large vaccination programs, and the contribution of Streptococcus pneumonia to pneumonia has increased very, very much, but there has been concern about the increase of resistance in pneumococcal strains to antibiotics after the introduction of PCV. Now, I found a publication from Europe, from Switzerland, and Switzerland, I think, is kind of a very good example. They do better than most other countries because they have a very good surveillance system, and they looked at the antibiotic resistance in pneumococcal strains, whether they were non-invasive or invasive isolates, pneumonia. And you can see that in children and in younger adults, about 30% of the isolates were still identifying serotypes that were not included in PCV13. And in older adults, you can see that this proportion increases in non-invasive streptococcal pneumonia isolates compared to the IPD isolates. Here you can see that actually the non-invasive, of course in Switzerland and as in most countries, the vaccination is done in children, and you can see that the non-invasive isolates came mostly from children and in very small parts from older adults, and that the invasive isolates were observed in the older population. And in Switzerland, you can see that the antibiotic non-susceptibility, so the resistance, is quite low. And what is most important, and what the authors of this publication wanted to show, is that there is no increase in antibiotic resistant strains in Streptococcus pneumonia after vaccination, but rather a decrease, which is significant in toddlers and small children, not significant in older adults, but at least you have safety data showing that antibiotic resistance would not increase after the introduction of pneumococcal vaccination, at least in Switzerland. Now, immunization, of course, remains a primary tool to prevent pneumonia in children and adults. And I would just like to show 2 or 3 slides about vaccination, things that you all know, but just insist on the fact that the pneumococcal vaccine, PPV23, has not been shown to be able to reduce pneumonia. There is no conclusive evidence. There is maybe a weak effect, but we have the data from the CAPITA study about PCV13 with good reduction in vaccine type, pneumococcal bacteremic and non-bacteremic community-acquired pneumonia. And of course, you know that we have lesser vaccine efficacy in influenza vaccination in older adults, but an interesting effect, and I'm sorry, the figure here is not very readable, I'm afraid, but there has been a recent publication. There have been several publications and a recent meta-analysis suggesting that the association of both vaccines has additive effects and could reduce pneumonia and mortality by around 25%. So let me finish with some remarks about knowledge gaps. Just a short remark with the CAPITA trial. Unfortunately, the really oldest old were underrepresented, and there was no significant result for reduction of Streptococcus pneumonia in this subgroup. And then, of course, with the results that we have from the microbiological samples, we always have to be aware that most of the microbiological samples are taken in patients that are hospitalized, and that we do not really know what the microbiology would be in patients that were treated at home, at the nursing home, and not been hospitalized. We don't really know what the microbiology is in patients that are not able to provide sputum. And the question, of course, is if in prospective studies we can prove that the molecular biology will help us to reduce antibiotic use, to reduce the resistance to antibiotics that we use, and that it will really influence patient outcomes, because it's very nice to document a lot of pathogens, but if it cannot change the outcome in our patients, then maybe it still is not very useful. So let me conclude. When looking at pathogens, molecular techniques for timely identification are promising. They are useful even after the initialization of antibiotic treatment. Of course, we have to be aware of increasing antibiotic resistance. When using vaccination, pneumococcal vaccination, we're always confronted with serotype shifts, but we are not, as far as I base my information on the Swiss study, confronted with increased antibiotic resistance in the remaining strains. Probably there is an additive value of dual vaccination, influenza and pneumococcal vaccination at the same time in older adults. And as I said, we will have to see if the better microbiological samples and de-escalation will lead to better prognosis and less resistance. Despite the insights in microbiology and antibiotic therapy available, the mortality remains high, hence the importance of vaccination strategies, which will be the subject of other talks at this Congress. Now, for the host factors, as the health burden will increase, we do not only have to look at the pathogens, we also have to look at the patients that have these pathogens, and we should be we should focus on silent aspirations that have been recognized as being the main mechanism leading to infection. We should have a look at medication, whether this leads to dry mouth and increased swallowing problems, or also reduced symptoms of pneumonia. Denture is important, good oral hygiene, of course. Sarcopenia should be addressed in older adults also as well in order to improve the risk of respiratory infections. And the atypical disease presentation is a classical situation in older adults and, of course, exists in lower tract infections as well. So I thank you for your attention, and I'm ready to answer your questions.
Antonio Cherubini from Italy. Thank you very much for the excellent presentation. In one of your first slides, you showed a difference in mortality between Europe and US, which was quite substantial for lower respiratory infection. Are there any explanations for that?
Not right away. I'll have to...
I would assume the guidelines are pretty similar in advising the antibiotic treatment, and so to have a difference in mortality, it was almost 20% for this situation, is remarkable, I would think.
Yeah, I think it probably is due to the patient factors, but I couldn't just give you details right now on that difference. I'm sorry.
Timo Strandberg, Helsinki, Finland. Thank you very much. Very, very nice presentation. There's one thing in all the patients. It's very usual to have almost routine to have these acid pump inhibitors in use. What's your view on that? What's their role in sort of a susceptibility to infections?
Well, if you reduce the gastric acidity, you increase the risk of having microbial colonization, and that will increase the risk of infection. So the tendency these last years certainly is to reduce the use of proton pump inhibitors that have been much too much used for prolonged periods in our patients. I think they are very good. It's very good medication, very helpful, but many times they are initiated and then not stopped anymore. And I think we should regularly reevaluate that.
Christian Teilacker from Pfizer. Two little comments. One about the study that you showed that appeared in Clinical Infectious Diseases by Kate Templeton about the etiology of CUP. Very nice study, but if you look in the methods, it's only patients that had a sputum available. And we know, only 40% roughly can elaborate a sputum. So 60% still we have an unknown etiology. And I think in that also the Haemophilus influenza, that it's the top pathogen, was a bit surprising. But if you look at the patient characteristics, they had a lot of COPD patients. 40% had COPD, so this maybe explains why this was a little bit deviant. And then just one little comment on the PCVs and antibiotic resistance. I think we have to have a little bit of a closer look here. So we had an expansion of the serotype 19A after the introduction of PCV7. And then when PCV13 introduced, which included serotype 19, in many countries we saw that in serotype 19A they associated antimicrobial resistance against penicillin and macrolides, reduced in many settings.
Yeah, I completely agree with your remarks. We have the first remark was about the documentation of pathogen by molecular techniques, and as I said, most of our patients, if you look at the French study, they showed that we have sputum in very small proportion of our older adults. So of course that remains an area of lack of knowledge, and there may be differences because the comorbidity and the patient profile can be very different in the patients that are not able to provide the sputum. And with the PCV, as you say, there is some serotypes that are more known for antibiotic resistance, the 19A, the 9V, and so on. And as you say, with the PCV13, this has been reduced, and the data from, as you saw from the United States, did not include the data from PCV13 yet.
Thank you, Ingo, for your presentation. Gaëtan Gavazzi from Grenoble, France. Don't you think that the real gap that may explain a lot of disagreement in between studies is the problem, the issue of the diagnosis? My feeling in a daycare hospital is that half of pneumonia coming from emergency department, and in the I would say they said it's pneumonia. Half of them are not pneumonia, and in studies we are you know, in France we have 7 definitions of pneumonia. Healthcare associated pneumonia, pneumonia associated with in nursing home, etc., etc. So don't you think it's the major gap we have now?
Well, of course, one thing is also non-infectious origins of syndrome looking like pneumonia, which we always have to be aware of. And as you say, my feeling as well is that when you look at patients seen at the emergency department, antibiotics are started right away. So even if the patient is not in critical situation and if there is doubts, they would start antibiotics anyways in order to kind of feel safe. So that is something I think we should work on. Now, with respect to the definitions, you're right, there is so many different definitions, but I think the recent tendency is to reduce that again. For example, the healthcare acquired pneumonia category is kind of disappearing because many of them do not have the pathogens that would resemble hospital-acquired pneumonia as initially expected, and they would respond to classic antibiotics as well. So there's some of these, I think there was a tendency to split it up in many categories, and now we see that many things resemble each other. Hospital-acquired, ventilation-associated are closer. Nursing home, in one of the slides you could see that actually the nursing home acquired pneumonias did very well in terms of response to classical antibiotics like amoxiclav and so on. So they may be closer to CUP, and I think it's expected in the next guidelines that there would be a regrouping of many of these diagnostic categories.
Thank you for your nice presentation, Pierre Béguet from Paris. After some years of immunization for infants and children in the States, they showed that the grandparents, great-father, great-mother, had lower Streptococcus pneumoniae infections. What do you think about that?
So you allude to herd protection. Well, that is something, if we look at, also if we look at the PCV13 data from the CAPITA study, actually we know it works in adults, but this study could not give an answer to what would have been if we first started with vaccinating all the children and then do the same thing in older adults. And maybe a big part of the effect might have been obtained by childhood vaccination and herd protection. Thank you.